Welcome to Podcasts on Demand, a continuing medical education activity. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 2 of 2 of the Expert Insights on Vitiligo, How Do Emerging Treatment Options Have the Potential to Transform Patient Outcomes podcast series. I am Dr. David Rosmarin, and I am joined by Dr. Chovatiya. This series provides expert interpretation of new data for current and emerging treatment options of vitiligo, along with practical considerations for how new agents can impact patient outcomes. A case presentation is discussed to help clinicians select the most appropriate treatment, as well as address the significant health burdens and complications experienced by many patients during treatment. We will discuss existing treatments, including topical and systemic immunosuppressants, phototherapy, and surgical techniques, which together may serve to halt disease progression, stabilize depigmented lesions, and encourage repigmentation. We will also discuss how to optimize the current available treatments and highlight emerging treatments that may improve treatment efficacy in the future. Thank you for joining us on this educational series on vitiligo. So let's go over the epidemiology. And we believe that vitiligo affects about 1% of the population, and that's true in the United States as well as worldwide. So that's where we get our estimates of 2 to 3 million people affected within the United States. And we know that vitiligo can affect all races, ethnicities. It can affect people at any age. However, it often affects a younger population, so much so that about half of the people will develop vitiligo by the age of 20 and up to 80% by the age of 30. Now, in terms of the estimates of how many people who have vitiligo, one of the challenges is there may be people out there that don't know that they have vitiligo. Maybe they're fair-skinned and they don't realize that they have lighter spots that are vitiligo. And that's where this estimates that maybe up to 40% of adults may be undiagnosed. And that's part of the reason why it's so challenging to know how many people in the US really have this condition. But we believe it's around 2 to 3 million. In terms of how do we categorize vitiligo, there have been different ways in the past, but we predominantly use non-segmental vitiligo or segmental vitiligo as our two main categories. And when we say vitiligo in general, you're really referring to the non-segmental type. It's just strange to refer to a negative as what's the predominant type of vitiligo. The segmental type is predominantly localized to one area. Some people, one segment really. Most often on the face, the second most common area would be the trunk. Commonly occurs in a more pediatric population, and there's rapid expansion of vitiligo over 6 months to 2 years, upon which time it stops and stabilizes. There's also more white hairs or leukotrichia, which is associated with the poorer prognosis. Now, in contrast, the non-segmental vitiligo is more often symmetric. It likes areas that are naturally hyperpigmented, such as the face, particularly around the mouth and eyes, elbows, axilla, genital region, dorsal hands and feet. And it can be active or stable, and that can switch at any point in life. And for the purposes of this talk, we're really going to focus on that more common type of non-segmental vitiligo. I do want to note, though, that patients can have a mix of type of both non-segmental and segmental as well. But for the most part, when we say vitiligo, we're really talking about that non-segmental type. And a practical tip is you always want to comment if the patient has non-segmental vitiligo in your medical note. Why? Because insurances may use that as a reason to deny treatment. So please document if it's non-segmental vitiligo. That can help patients get the therapy that they deserve. So in terms of vitiligo, the first thing that I always try to differentiate after figuring out is it non-segmental or segmental is the disease active or is it stable? And the number one concern for our patients is whether the disease is spreading or not. They have more anxiety over whether they'll get new spots or not than any other feature with the vitiligo. So there are four main types that are associated with vitiligo being active or spreading. One is if they have trichrome vitiligo, which you can see in the upper left, where you see the normal skin, the depigmented skin, and then a third color in between. Second is if they have confetti vitiligo, as you see in the upper right, which is 1 to 2 millimeter depigmented macules. Third is if you see the Kevner phenomenon, where maybe a scratch induces vitiligo. And then last, which is very rare, very uncommon, is inflammatory vitiligo, where there is a erythematous ring around the vitiligo. It's not red throughout, but there's a annular erythema to the vitiligo. And it's a little bit more associated with pruritus as well, because typically vitiligo is asymptomatic. Raj?
Yeah, let's touch a little bit on the burden. Now that we have an idea about what we might be looking for and how potentially common or undiagnosed vitiligo actually is. I mean, there's an obvious component to this discussion that vitiligo is visibly something that you can notice. It's a highly visible diagnosis. And just given that what you see is so closely intertwined with your own personal identity, you can imagine what a major burden this probably creates on individuals experiencing vitiligo. And based on a number of different studies, you can document in terms of various scoring systems, reduced quality of life, changes in self-esteem, isolation, interpersonal relationships getting disrupted. We know that stigma, particularly in certain countries where vitiligo can be associated with really questioning one's marital status or eligibility for marriage itself, potentially a reason or grounds for divorce, or an idea that somebody might be infectious and other, therefore they're kept away from individuals, as we've noticed throughout years of history. There's an increased risk for comorbidities that we oftentimes don't necessarily think about all the time. In the case of vitiligo, it's not really just an asymptomatic skin rash and nothing on its own. Mental health disorders, including depression, is a really big one, especially in sort of many of our adolescents and young adults, where we know that there is a higher prevalence of some of these mental health conditions. And we know that there's a strong overlap on vitiligo and psychosocial burden. And of course, those that have darker toned skin may be profoundly affected because, as you heard, with those individuals that have lighter toned skin, it may be a little more subtle to actually see the signs of vitiligo, but it's much more apparent in somebody that has much more dense pigment concentration. So let's talk a little bit about those comorbidities then that I just mentioned. Vitiligo is really not just a skin disease, right? So vitiligo can be associated with a variety of different autoimmune, connective tissue diseases, systemic and dermatologic conditions. We oftentimes think about certain autoimmune conditions, most commonly with vitiligo. Thyroid-related disease is one of them, but there are others in general. If you have large enough sample sizes, you can usually find a statistically significant association with a whole host of conditions cross-sectionally based on some of these large database analyses. In general, if I had sort of a diagram of the human body up here, you would see that there's really potential association with diseases involving all sorts of body compartments and body systems. Additionally, it's worth noting that when it comes to thinking about the skin in particular, we oftentimes, as dermatologists, are thinking about skin cancers and melanoma. We know melanoma is, of course, related to the actual presence of melanocytes and melanin. There's actually a threefold less risk for melanoma versus the general population. This has everything to do with sort of the actual milieu of skin cells that are left in somebody that has vitiligo. Back to you, David.
So now we're going to talk a little bit about the pathophysiology of vitiligo, which has been better elucidated more recently. It's really interferon gamma that is driving the pathophysiology. So just to review some of the results of these cytokines is that we know that when you have a disease like psoriasis, that's Th17 driven. And cytokines like interleukin 23, interleukin 17, and TNF are really key cytokines in the pathophysiology of psoriasis. In contrast, we have atopic dermatitis, which is primarily a Th2-driven disease, and some key cytokines are interleukin 4, 13, interleukin 5 and 31 are also involved. Interleukin 31, sometimes we refer to as the itch cytokine, so that's where interleukin 31 comes in. And in contrast, vitiligo is fundamentally a Th1 disease. It's interferon gamma driven. And there's some kind of stress that can be triggering to the pathophysiology, but ultimately it's interferon gamma that's signaling to our T cells through the JAK-STAT pathway, particularly JAK1 and JAK2. And it's those T cells that are then going back and destroying the melanocytes. Now, some other signaling molecules that are involved can be these signaling chemokines like CXCL9, CXCL10, which are involved with recruiting those CD8 positive cytotoxic T cells to destroy the melanocytes. But fundamentally, that's the problem. And I also want to comment that even after we treat vitiligo, sometimes the disease comes back. And why is that? Well, we have these resident memory T cells that are still remain, which are dependent on interleukin 15. So based on these cytokines and these signaling molecules that are involved, well, that's where we're going to try to target to get our patients better. And through the work of our scientists, really to elucidate that it's the Th1 pathway, that's really the key at helping develop new emerging therapies that are going to be effective for our patients. So how would we treat a patient like this in vitiligo in general? Well, the first thing that I mentioned I try to assess is the vitiligo spreading or is it stable? Very important to determine that. Now, if it's spreading, my first goal is to stabilize the disease. And the primary way I would do that is with oral corticosteroids. And there are studies showing that dexamethasone, about 2.5 milligrams, given on 2 consecutive days for about 12 weeks, stabilizes disease in about 90% of patients with really minimal side effects. So I think that's one of my main strategies. Now, if that were not to work, you could always try doing that for longer or increasing the dose up to 5 milligrams of dexamethasone on 2 consecutive days for another 12 weeks or so. Now, another option to help stabilize the disease and can also help start the repigmentation process would be phototherapy, particularly with narrow bands, UVB. So those are the 2 main options we have for helping stabilize our patients in terms of the vitiligo. Now, once we accomplish that, the next question is, well, how do we help treat these patients really effectively to help with the repigmentation process? And for that, we are basically dividing patients into those who have very localized disease where topical makes sense, so maybe 10% or less of the body surface area, or patients who have more extensive or generalized involvement. For patients who have more localized disease, we're thinking about topical treatments. And that includes really 3 main options. 1, corticosteroids, calcineurin inhibitors, particularly tacrolimus ointment, and then 3, ruxolitinib cream, which is currently the only FDA-approved treatment for repigmenting non-segmental vitiligo. Now, if patients have the disease more moderate or severely, we may also discuss with them more systemic options, such as narrowband UVB phototherapy. And some key there is that it's not the frequency of treatment, but the total number of treatments that patients get that's ultimately responsible for their final result. Also, some people may use oral JAK inhibitors, which are off-label. In terms of using PUVA, that's really not used as much anymore because our studies show that narrowband UVB is more effective than PUVA. So we really discourage that use. Other options that we also look to more as 3rd and 4th line treatments can be basically melanocyte transfer. So if a patient has stable disease and we're sure it's stable, and they don't have the Kebner phenomenon, and they have a small area, they may be a candidate to take melanocytes from normal skin and transfer them over to the depigmented areas, and patients can have great results that way. And then lastly, for certain candidates that may want complete depigmentation, we have certain options such as monobenzone. However, there are very few people who really fit as good candidates for that option, but the ones who do it can have quite high patient satisfaction. Now, one thing that we're also in the process of studying is concomitant treatment. So it may be that topical treatments or systemic medicines that help suppress the immune system combined with phototherapy may even be better than either alone. And so that's currently under investigation, and we think that strategy might work. So utilizing our topical corticosteroids, calcineurin inhibitors, or JAK inhibitors with narrowband UVB phototherapy or excimer laser is often our go-to option for our patients. If patients can't do the phototherapy due to inconvenience, and perhaps just starting out with one of our topicals. Thank you, Dr. Chovatiya.
So let's kind of jump into some detail about what Dr. Rosmarin just told us about. And so in general, treatment is centered around a few simple principles. We're trying to essentially stabilize disease, so stop depigmentation. We're then trying to drive repigmentation and get us to a point where things can stay stable. And so as you can imagine, this is a multi-step process, so this takes time. We're so used to thinking about a world in dermatology that's on the order of weeks, even a few months, but this whole process is a multi-month, if not longer process. So in terms of really trying to get rid of that oxidative stress, correct an aberrant immune response, and create an environment where melanocytes can regrow and proliferate, you're really trying to do a lot of things with vitiligo therapy. So there's a lot of different things that can impact therapeutic outcomes. Some sites of the body tend to repigment better than others. A lot of this has to do with follicular density, knowing that that is the reserve around the follicle region where many of these melanocytic progenitors might reside. So something like the face does a way better job than, let's say, somewhere around the hands where there really isn't sort of that much density going on. Additionally, there's other factors to touch on in terms of sort of how long someone may have had disease, how old they are, sort of duration of therapy, whether or not you're seeing sort of total whiteness of the hairs or lesional white hairs, leukotrichia. Typically, that's a sign that there really isn't a pigment left in that reserve, meaning that you're not really going to be able to get functional melanocytes migrating out and repopulating an area. Additionally, confetti lesions and trichrome lesions as signs of really rapidly progressing disease as well are things to look out for. Now, we talked about some of those topicals, and let me kind of review what we used to have before Dr. Rosmarin jumps into sort of some of the newer stuff. In general, topicals are first-line therapy for limited disease. Maximum repigmentation of face and neck is kind of what's clinically been observed. Topical corticosteroids, of course, are readily available, fairly cheap, and found in a variety of different formulations. They seem to work when you combine them with narrowband UVB as opposed to by themselves, where they're not as effective relatively. Usually your maximal results are happening somewhere in the mid to high potency preparations. You are going to be limited by potency for particularly sensitive body areas, just like the face. Chronic topical corticosteroids can drive atrophy, acne, telangiectasia, loss of subcutaneous fat, even sort of other pigmentary problems on pigmented skin as well. So something that is just a major drawback for chronic topical corticosteroid therapy. We know that with calcineurin inhibitors, they also have efficacy that's been documented over time, also particularly alongside light-based therapies like narrowband UVB or eczema. You don't have the steroid-related complications, which is nice, but there can be other cutaneous adverse events like sort of stinging or burning that can go along with calcineurin inhibitors that can limit their use in some individuals. Additionally, long-term use in maintenance therapy, that's kind of a place where they shine. And sort of some individuals will try this initial approach with a stronger topical steroid, then pull back from maintenance with topical calcineurin inhibitor. Phototherapy is another really important modality. I know Dr. Rosmarin uses it quite a bit. I do as well across inflammatory diseases, but particularly in vitiligo. We know that narrowband UVB especially is the one that balances efficacy with safety in terms of sort of relatively low to not really any sort of definite documented skin cancer risk compared to PUVA, which was a UVA-based therapy that involved use of a swirlin as well, which was historically used quite a bit, but does have certain risks and limitations on how long you can use it. So you can see here in this meta-analysis of a number of studies, there was actually a pretty moderate response in about 37% of individuals at sort of 6 months and 57% at 12 months, and a market response sort of in sort of relatively good numbers as well, but particularly with the longer treatment. And you can see that this extended sort of not only across the face and neck region, but other body areas, as I mentioned, the hands and feet in general, which are oftentimes very, very tricky when we're thinking about driving repigmentation. Autologous grafting is another one that's worth mentioning, noting that this isn't going to be a technique found everywhere. It's usually going to be specialized areas. And so stable focal and segmental vitiligo can be helpful here when you have areas that are not responsive to medical therapies. You could have suction blister grafts, melanocyte transplants, punch grafts, sheet grafts, essentially trying to take healthy melanocytes or particularly melanocytic progenitors into areas where they don't exist and allow their proliferation. So that's kind of the grafting aspect of it. And you can graft tissue or cells in a variety of different ways. Maximal results, of course, are going to be used in conjunction with phototherapy. There is some long-term follow-up that suggests this could be beneficial, but as you might imagine, given this somewhat of physical modality, there can be limitations on where you might potentially be able to get this type of treatment. So in the case of our particular patient, she's tried topical corticosteroids without relief. She's had extensive periorbital and eyelid involvement, making those not great options for her. She's used topical calcineurin inhibitors, the tacrolimus that was mentioned by Dr. Rosmarin. Really no appreciable improvement after 3 months of twice daily use. Let's talk a little bit about the last part of this case, and then we're going to get into JAK inhibition and signaling with Dr. Rosmarin. So for this patient, ruxolitinib 1.5% cream, a topical JAK inhibitor that is indeed indicated for non-segmental vitiligo, remember those words and document them well, was prescribed to be applied twice daily to the affected areas. Take it away, David.
In order to understand why JAK inhibition and ruxolitinib cream makes sense, we have to go back to the pathogenesis. And vitiligo is fundamentally an autoimmune disease. And key is that it's not a cosmetic condition, it's a medical condition, it's an autoimmune condition that's driven by Th1 cytokines, particularly interferon gamma. And how is interferon gamma signaling? Well, when it binds to the receptor on the T cell, it then signals intracellularly through JAK1 and JAK2, which activates the STAT and causes a transcriptional programming, which leads to killing off of the melanocytes. A key to this positive feedback loop and part of the problem with vitiligo is that the signaling is taking place through JAK1 and JAK2. So if you block JAK, you're blocking the interferon gamma signal, which is what will help patients get better when they have vitiligo. And you may say, well, don't our other topical treatments do that? Well, corticosteroids and calcineurin inhibitors, well, they can be good at certain disease axes, like for eczema and for psoriasis. They tend to not really work well when it comes to interferon gamma suppression. And that's why JAK inhibitors really play a particularly well-suited role for vitiligo, is because they have very good activity when it comes to suppressing the interferon gamma axis. So again, vitiligo, it's fundamentally autoimmune in nature. JAK is part of that signaling pathway through interferon gamma. And ruxolitinib cream is our first and currently only FDA-approved treatment for patients with non-segmental vitiligo. And it's approved for both pediatric and adult patients that are 12 years of age and up. It's used twice a day. And we have both short-term and long-term data showing its efficacy and safety, which we're going to review. So this was the primary endpoint for the two phase 3 programs, TruV1 and TruV2, which were identical. The primary endpoint was at 24 weeks, and that at that time it was vehicle control, but then at 24 weeks, all patients received ruxolitinib cream, and we have more data for the 52-week mark. And we can see here that in both studies, about 30% of the patients achieved this FAAD 75 at the 6-month mark, but it jumped up to about 50% of patients at the year mark. So you can tell about half of your patients are going to get 75% or more of their pigment back on the face at a year. And that's very consistent, not only amongst the phase 3 results that we see here, but also amongst the phase 2 results that we see. It's very robust, that number, that's about the percent of patients that improve. And the key with discussing with patients is not to rely on the 24-week mark, because unlike other conditions such as psoriasis and atopic dermatitis, where most of the improvement happens early, in vitiligo, the repigmentation process takes time. You really want to make sure that patients are giving it not only a year, but even up to 2 years, really, for improvement, because our studies show that even more benefit is gathered by our patients beyond the year mark. Also, some of our studies show that in patients who are partial responders, well, they can still achieve an FAAD 75 if they still are using the medicine beyond the year mark. So I think that's all really important information to give to patients and counsel them about their expectations. If they expect to get better in 3 months or 6 months, that's not the right expectations. They really need to go into the mindset that they're going to be using this for about 2 years. Some patients may even need more. But with continued use, we're seeing continued benefit. Now we're going to look at some pictures of patients who use ruxolitinib cream in the phase 3 program. So this individual had about half his face or more depigmented with vitiligo. We see a baseline. Already at 12 weeks, we see significant repigmentation, and by the 6-month mark, really is largely repigmented. This would be a very early responder that was from the study. The next patient we have is a teenager who had depigmentation around the eyes, nose, and mouth. And at the 12-week mark, you can see significant repigmentation around the eyes, but then not until the 24-week, and I think this is mislabeled. It's actually week 52. Oh, sorry, this is correctly labeled. In week 24, we see really nice repigmentation around the eyes, but the mouth is not fully repigmented yet. What I will comment on is knowing this patient is that at week 52, she then did get her pigmentation back fully around the mouth. What I also really like about this picture is you can also see one of the side effects of ruxolitinib cream. About 6% of patients will get application site acne. And here she has a little bit of acne at baseline. You can see that in her forehead. And perhaps it's a little bit worse at the 6-month mark in the cheeks. Now, all the patients, it's really mild or moderate. No patients had to drop out of the study due to this. And really, in my experience, patients don't discontinue the treatment. It's usually mild, and we can treat it with the normal ways that we use to treat acne. Here is a patient whose hands also showed improvement. As we now know, ruxolitinib cream is not just for the face, it can help improve the body. And even though the hands are a very recalcitrant anatomic site, patients can still get improvement there. Here we see an extremity that's also repigmenting in nicely in the follicular way. But the right advice for this patient at week 24 is to keep using the medicine. They haven't hit their maximal response yet. In terms of some key findings from ruxolitinib cream, it's that we're seeing even more patients improve with continued use of the medicine, so that even though it's 50% of patients achieving an FAAD 75 at the year mark, we're seeing even higher numbers at the 2-year mark. And it's also the same is true for the body as well. Patients who are not super responders on the body, with continued use of the medicine, they'll see continued improvement. So on average, about half the patients at the year mark will have a 50% or more improvement on the body. Sorry, if we look at the data, about 6% of patients in the study had application site acne, almost always mild or moderate and not leading to discontinuation of treatment. Also, about 6% of patients can have application site reaction like pruritus. And again, these are also often mild. One of the reasons why we like to use ruxolitinib cream as a topical is because you help minimize the risks of a systemic agent. So we weren't seeing wholesale neutropenia, anemia, or other side effects, which may be uncommon, but you can still get with systemic JAK inhibitor use. And oftentimes I'm asked, do I monitor the blood with patients who are Rux cream? And the answer is no, because it was these side effects were monitored in the phase 3 study, and we weren't seeing signals for lab abnormalities. I don't check it in clinical practice either.
So with that being said, let's kind of wrap things up with some closing thoughts here first. So a couple of things that I want to touch on, David, and then sort of I'll let you sort of add yours as well, is that really vitiligo is about the whole person. It's not just what you see on the skin. It's not just the pigmented patches. But in this particular case, quality of life, mental, physical, psychosocial burden, and mental health symptoms in particular are key. And you have to understand that, like a lot of other inflammatory diseases, you really need to look beyond just what you see on the skin. That psychological burden, for instance, is just the one that's so well documented. And there is a fascinating history of vitiligo and the way that it's created unique burden in various cultures and civilizations throughout history.
So I can't echo that enough, that what Dr. Chovatiya said is that this can have really a big effect on patients, and it's really important not to make assumptions either. So you may think that a patient who is very fair-skinned is not affected by the vitiligo, but they really might be. Similarly, some patients who may have very noticeable vitiligo but aren't bothered by their disease. So you never make assumptions and always need to have that shared decision-making process with patients. In terms of the pathogenesis, we really have now well established it's fundamentally a Th1 disease driven by interferon gamma through the JAK-STAT signaling pathway. Therefore, it makes a lot of sense to think about a JAK inhibitor as a treatment, and it's been proven to work not only in multiple studies with the topical, but there are now systemic oral JAK inhibitors that are also proven to help repigment patients with vitiligo. So key points here are that you can make a big difference in these patients' lives, not to make assumptions, and really help them out in a compassionate way that dermatologists know how.
Hopefully you enjoyed what we brought you guys tonight. It was a real pleasure, David, to participate with you and sort of taking a really rapid fire look from top to bottom at vitiligo and really thinking about where we've come and where we're going.
Thank you for listening to this episode of Expert Insights on Vitiligo. How do emerging treatment options have the potential to transform patient outcomes?
We hope you found this podcast useful and educational.